My name is Christian Ruff. I'm the Director of General Cardiology at Brigham and Women's Hospital and an Associate Professor at Harvard Medical School. Our learning objective today is to recall strategies to develop patient-centric treatment plans that include appropriate anticoagulation therapy and patient education. Let's begin with screening and diagnosis, the who, when, and how. Let's talk about monitoring across disease stages. And really, it's important to know where your patient is in the history of atrial fibrillation because that sort of determines how closely we're going to monitor the patient. We might have a patient who doesn't have atrial fibrillation, just has risk factors. We may not do much monitoring for progression at that time, but as they develop pre-atrial fibrillation, where they have evidence that predisposing them to being clinical atrial fibrillation, we might heighten our surveillance. And certainly once a patient has established atrial fibrillation, we're going to be talking about intensive surveillance to monitor the efficacy of both rhythm and rate control, as well as anticoagulation. How do we identify individuals who are at risk for developing atrial fibrillation? Well, we know there are many risk factors for atrial fibrillation. It's one of the most common diseases that we encounter in all of medicine. Some common ones are obesity, lack of physical fitness, hypertension, sleep apnea, alcohol, and diabetes. Those are all modifiable. It's really important to look for those because we could do something about those factors to lower their risk. Other things are, of course, non-modifiable. Their age, their genetics, etc. But we want to be really closely following for symptoms. Those are palpitations, dyspnea, fatigue. Those are the most common ones. But it's important to know that the majority of patients, somewhere between 50 to almost 90%, are initially asymptomatic. So just relying on symptoms alone is insufficient. So if we're worried about atrial fibrillation, how can we identify it? Well, there are really several ways. Of course, for many decades, we've been doing electrocardiograms, and certainly that's a very useful way to screen for atrial fibrillation. It's like checking someone's pulse. Is it irregular? Is it fast? There are more sophisticated ways we can do that now. There's long-term and plannable monitoring. Patients are wearing smartwatches, as well as insertable cardiac monitors. All of these are valid approaches to identify or screen for atrial fibrillation. But the important part of all of these is that you need to document atrial fibrillation electrically. So you have to visually confirm that electrical readout and determine that it in fact shows atrial fibrillation, no matter which screening mechanism that you employ. Let's talk about guideline-recommended anticoagulation therapy. So our most current ACC/HA, ACCP, and HRS guidelines just published in 2023 really outline the pillars of management for atrial fibrillation. Of course, we want to reduce stroke. We want to manage the symptoms of atrial fibrillation. But it's critical to remember that the underpinning of all of these recommendations are modifying a patient's risk factors for atrial fibrillation. And those are critical because we know that whether they're heart failure, lack of exercise, hypertension, etc., identifying those risk factors and treating those risk factors help us prevent atrial fibrillation, but also improve outcomes in patients who have established atrial fibrillation. It's time for a question. For a female patient with non-valvular atrial fibrillation, which basically means atrial fibrillation without moderate to severe mitral valve stenosis or mechanical heart valve. So really most patients of valvular heart disease are covered by our recommendations in the guidelines. Which of the following is true? A, as patients with non-valvular atrial fibrillation, she should be prescribed a DOAC for anticoagulation. B, as a patient with non-valvular atrial fibrillation, she should be prescribed warfarin for anticoagulation. C, anticoagulation is recommended and a DOAC is preferred if her CHA2DS2-VASc score is greater than or equal to 3. Or D, anticoagulation is recommended and warfarin is preferred if her CHA2DS2-VASc score is greater than or equal to 4. Please vote. So what do our guidelines say about atrial fibrillation? Remember, there's a class 1 level of evidence A recommendation for anticoagulation in patients with atrial fibrillation and an annual stroke risk of approximately 2% per year or greater. That really ends up being a CHA2DS2-VASc score of 2 or greater in men or 3 or greater in women. And we do know that patients with atrial fibrillation who require anticoagulation, we generally want to be prescribing a DOAC over warfarin because it's equally as effective and much safer with respect to serious bleeding, particularly bleeding in the brain. We know that patients who have a lower CHA2DS2-VASc score, so less than 2 with a stroke rate somewhere around 1 or 2%, it's still reasonable to provide anticoagulation, again with a DOAC, but there's much more ambiguity there because their risk is lower. So it's certainly shared decision-making in those patients. So our estimation of risk really is enhanced by using dedicated risk scores. Now, the most common one we use is the CHA2DS2-VASc score, and it incorporates many of the common risk factors for atrial fibrillation. There were whereabouts such as age and hypertension, diabetes, heart failure, etc. There are others out there, the ATRIS score, Garfield AF, etc. But CHA2DS2-VASc is really endorsed by most of the guidelines throughout the world. It's the most validated. But of course, there are other features that one might add in patients who are indeterminate risk, where you're looking to see if there are other factors that may increase or decrease their risk if they fall in one of these in-between CHA2DS2-VASc scores. So let's go back to our patient. For a female with non-valvular atrial fibrillation, which of the following is true? A, as patient with non-valvular atrial fibrillation, she should be prescribed a DOAC for anticoagulation. B, as a patient with non-valvular atrial fibrillation, she should be prescribed warfarin for anticoagulation. C, anticoagulation is recommended and a DOAC is preferred, but only for CHA2DS2-VASc score is 3 or greater. Or D, anticoagulation is recommended and warfarin is preferred if her CHA2DS2-VASc score is 4 or greater. And the correct answer here is C. Of course, we want to prevent stroke, but remember, although patients have an increased risk of stroke, there's a continuum of risk. And for women, we generally have a threshold of a CHA2DS2-VASc score of 3 or greater, which corresponds to an annualized risk of stroke or systemic embolism of 2% or more. And again, if we are going to anticoagulate, we reach for a DOAC because it's enhanced efficacy and safety profile. So when we talk about stroke prevention in atrial fibrillation, we're really talking about anticoagulation. And as I mentioned, we have two broad options, the DOACs, which are the factor 10 or 2A inhibitors, or warfarin. And we know from seminal phase 3 clinical trials studying the DOACs versus warfarin that DOACs are really the superior strategy. They're as effective in reducing stroke, but they're far safer with respect to serious bleeding, particularly intracranial hemorrhage or bleeding in the brain, reducing that by over 50%. And that really leads to a mortality benefit with the DOACs over warfarin. We still do see bleeding on DOACs, but less bleeding than we see with warfarin, really with the exception of gastrointestinal bleeding, which is still common with all of the anticoagulants. So time for another question. Which statement is true? A, all DOACs are appropriate for people with a creatinine clearance 15 to 30 milliliters per minute. B, all DOACs are contraindicated for people with a creatinine clearance less than 15 milliliters per minute. C, DOACs are appropriate for patients any degree of liver disease. D, DOAC dose adjustment is required for people with mild liver disease. Or E, DOACs are not reasonable options for stroke reduction in people with a BMI of greater than or equal to 40 kilograms per meter squared. Please vote. Now, what about patients with impaired kidney function or chronic kidney disease? Very common in patients with atrial fibrillation, since we're talking about diseases of the elderly. Well, we know that patients with atrial fibrillation who have chronic kidney disease, they're at higher risk of stroke. CKD is actually a risk factor for stroke, even though it's not included in our CHA2DS2-VASc score. And we do know that the NOACs are as effective in patients with mild to moderate CKD, certainly to a CKD stage 3. We know as patients progress more towards end-stage renal disease, we have less data to inform our decision. We do know in patients with CKD stage 4 that you could consider warfarin or labeled doses of DOACs. We're often using a dose-reduced dose of the DOACs in those patients to reduce the risk of stroke. And of course, where we have the least amount of data is really patients who have end-stage renal disease, those with a creatinine clearance less than 15 or on dialysis. We don't have any randomized controlled trials to inform our decision about anticoagulation in these patients. We do know that warfarin has been used for a long time in end-stage renal disease, although warfarin performs very poorly. We do have observational data that some of the DOACs actually seem to perform relatively well in these patients. And the US guidelines actually recommend an evidence-based dose of apixaban potentially for these patients, given apixaban's safe bleeding profile, even in patients with end-stage renal disease. One of the interesting questions that comes up is, I've told you it seems to be reasonable to use DOACs throughout the spectrum of chronic kidney disease, but actually there's a preference for DOACs because DOACs are actually help to protect the kidney compared to warfarin. If we look at renal outcomes in clinical trials of warfarin versus DOACs, we see that warfarin is actually harmful to the kidneys. It leads to calcification of the renal arteries, and that accelerates renal decline. Patients are more likely to have progressive kidney disease, have acute kidney injury, etc. So not only are the DOACs generally safe in patients with advanced CKD, but warfarin actually accelerates renal decline and makes it more likely that a patient will end up on dialysis. Now, it is important when you're talking about chronic kidney disease to use the appropriate dose in these patients, and it varies depending on what the agent is. So it's important to follow the labeled dosing in these patients to determine what the appropriate dose is in a patient with advanced CKD. Another question I know that I'm frequently asked is, should we be using DOACs in patients who are significantly obese, particularly with a BMI above 40? Now, the concern is maybe they're not absorbing enough of the DOAC, maybe because of their volume of distribution due to their obesity. Their levels of the DOAC are too low, and it's not going to be as effective as warfarin, which you can sort of titrate based on the INR. But actually, we've learned that this is not the case, that there's no concern for a loss of efficacy with DOACs in patients with obesity, regardless of their level of obesity. And the guidelines now reflect that even in patients with a BMI of 40 or above, the DOACs are really our preferred option over warfarin in those patients. What about patients with hepatic disease? Well, we know that all of the clotting factors are made by the liver. So there's always a concern about anticoagulation in patients with advanced hepatic disease. And none of the trials included patients with advanced liver disease. But we do know the guidelines say that in patients with mild hepatic disease or moderate liver disease, and that's really Child-Pugh class A or B, that we should be anticoagulating those patients. And again, the DOACs are generally the preferred strategy in all of those patients. Of course, as a patient gets more progressive hepatic disease, we do not have clinical trial evidence to inform whether we should be routinely anticoagulating those patients and what anticoagulant we would use. But generally, we do avoid the DOACs in patients with severe liver disease. So let's return to our question. Which statement is true? A, all DOACs are appropriate for people with a creatinine clearance 15 to 30 milliliters per minute. B, all DOACs are contraindicated for people with a creatinine clearance less than 15 milliliters per minute. C, DOACs are appropriate for patients with any degree of liver disease. D, DOAC dose adjustment is required for people with mild liver disease. Or E, DOACs are not reasonable options for stroke reduction in people with a BMI greater than or equal to 40 kilograms per meter squared. Please vote. So the correct answer here is actually A. All DOACs are appropriate for people with a creatinine clearance 15 to 30 milliliters per minute. Now, there's a variety of things that we're tackling in this question. The first is obviously patients with chronic kidney disease. We know that although all the DOACs are renally cleared, that they're safe, and we have good data with respect to their efficacy and safety, even down to a creatinine clearance of 15. So certainly patients with significant CKD, 15 to 30, all the DOACs have a labeled indication. Where we are not so sure we have a lack of data is in patients with end-stage renal disease with a creatinine clearance less than 15. There is guidance permitting the use of some of the DOACs, but not all. But that is an option for some patients. With respect to liver disease, the DOACs are really only contraindicated in patients with very severe liver disease. But patients with mild liver disease were enrolled in the trials. They can receive DOACs, and they do not need any dose adjustment. And lastly, there had been some controversy that the DOACs may not be good drugs in patients with significant obesity, particularly with a BMI of 40 or above. That turns out, with data that we have in the last couple of years, not to be an issue. The DOAC can be used across the spectrum of body weight and BMI, even in patients with a BMI of 40 or above.
Hello, my name is Laura Van Brocklin, and I'm a nurse practitioner that works in electrophysiology, or EP, at Denver Health in Denver, Colorado. I'm going to be reviewing with you considerations for patient-centered treatment plans. The considerations that we have when we're participating in patient-centered care are patient characteristics that might affect the decisions we make, characteristics of the oral anticoagulant therapies themselves, and then the pairing of the two. Lastly, we'll discuss some shared decision-making tools that you are able to use to support where you go with your patient. First, we like to start with a risk assessment. So we're balancing the risks and the benefits of oral anticoagulation. First, we take a complete history and then use a CHADS to VAS score. This involves evaluating anybody with heart failure or a left ventricular ejection fraction less than or equal to 40%, looking to see if they have hypertension, if they're greater than age 75, or we also consider the age of 65 to 74, whether they have diabetes, a history of stroke, TIA, or thromboembolism, and lastly, unfortunately, we have to consider whether they're female or not. In my clinical practice, I use the HAS-BLED as this helps us figure out whether or not an alternative to long-term oral anticoagulation can be considered, such as a left atrial appendage closure. The HAS-BLED is not specifically supported through the guidelines, but it is a tool that can be used through practice. So H is for hypertension. We also look at abnormal liver or renal function, as Dr. Ruff reviewed. There's also a history of stroke, bleeding, if they have a labile INR, which is our reading to figure out how their warfarin is working, if they're elderly, age 65 or older, and then also if drugs or alcohol are used regularly for this individual. Recommendations for oral anticoagulants for device-detected atrial high-rate episodes with no previous AFib diagnosis. These are patients who happen to have a pacemaker or ICD that helps us identify that they have an irregular heart rhythm. AFib is at high risk of creating stroke. So the guidelines recommend, these are 2A recommendations, that you get the patient in and reasonably initiate oral anticoagulation, but you use a shared decision-making framework that considers the episode durations and the individual patient risk for stroke. The second recommendation for patients with device-detected atrial high-rate episodes, it may be reasonable to initiate anticoagulation. These episodes last maybe 5 minutes to 24 hours and a CHADS VAS score of greater than 3. The shared decision-making framework would be a consideration again to try to decide whether it would be reasonable to start an anticoagulant for this patient. Patients who have device-detected atrial high rates of less than 5 minutes without other indication for oral anticoagulants should not receive oral anticoagulation. Our goal is to prevent thromboembolism, to prevent stroke. So, stroke prevention therapies include oral anticoagulants, factor Xa thrombin inhibitors such as apixaban, edoxaban, rivaroxaban, and then there is the factor II inhibitor, dabigatran. There are also non-pharmacological approaches that we use as well. We talked about how we use these in decision-making of whether or not the patient is at high risk of bleeding on these oral anticoagulants. So there can be a percutaneous left atrial appendage closure as well as a surgical left atrial appendage exclusion or excision. This is when they are already having open heart surgery. It's not typically done just in the setting of AFib. On our right, we have the coagulation cascade and where the oral anticoagulants affect the clotting in our blood system. The whole idea is to reduce the amount of fibrogen and fibrin clots that come out at the end of this pathway. When we consider patient characteristics, major considerations include age and renal function when selecting and dosing oral anticoagulants. Other specific populations that need special consideration would be those with vascular disease, such as acute coronary syndrome, have a history of PCI, PAD, adult congenital heart disease. We also need to consider chronic kidney disease, kidney failure, obesity, hyperthyroidism, pulmonary disease, pregnancy, oncology patients, and liver disease. The agent characteristics that we need to consider are the administration route and frequency, the metabolism of the drug itself, the substrate and drug interactions that could cause an issue, excretion, half-life, renal dosing, and use in liver disease and hepatic insufficiency. So in the management of active bleeding for our patients who are on oral anticoagulation, there is always the consideration and the need for understanding when and how to use reversal agents. For minor bleeding, we can take supportive measures, which include holding an anticoagulant until the bleeding has stopped. It can be pressure countermeasures or waiting it out. Next, if we have some active bleeding associated with an oral anticoagulant, if it's life-threatening bleeding or uncontrolled major bleeding, for factor Xa inhibitors, we need to consider the reversal agent adaxant alpha for apixaban or rivaroxaban. And then for edoxaban, we would also consider this. We can always consider using PCC to help out with the Xa inhibitors. This is always an option for any bleeding. For dabigatran, we would need to consider the reversal agent adaruximab is needed to reverse dabigatran. If needed, you need to take activated PCC if there is not the reversal agent available. Lastly, warfarin, you need to give vitamin K and PCC if needed. For non-life-threatening bleeding, just supportive measures, consider hemodialysis for dabigatran and hold an anticoagulant if needed. All of these are ways to reverse the oral anticoagulants, and this decision tree can be helpful in deciding where to go with your plan and when to consider using a reversal agent. As soon as you use the reversal agent, then they are at high risk for stroke, especially if they are currently in AFib. Let's review a question about when and how to move forward with your patient once you decide that they need to be on oral anticoagulation. You've determined that your patient is a candidate for oral anticoagulation therapy. According to the ACC elements of shared decision-making, which is the best option to engage in shared decision-making with your patient? A, give the patient information, have them select what they'd like, and order it for them. B, decide which oral anticoagulant is right for your patient and share it with them. C, tell your patient that oral anticoagulants are effective at preventing stroke, but don't scare them away by mentioning bleeding risk. D, use a decision guide to discuss available therapies with your patient. Shared decision making, things to consider each time an order is entered. Shared decision making has always been a part of practice, but it is now becoming more delineated in how we approach this with our patients. It's now integrated to the current ACC, AHA, and HRS guidelines for 2023, that this is a part of what we do when we're deciding whether or not to order an oral anticoagulant. The whole idea is to encourage conversations regarding medication and treatment options. All decisions should be made with the provider speaking in plain language regarding the outcomes of presented options. Also, use of resources for difficult conversations. As we mentioned, the ACC elements of shared decision-making includes recognizing there is a decision that is needed, discussing the risk and benefits of treatment options, such as risk assessments and tailored decision-making aids, as well as incorporating the patient's values and preferences into the decision before you're putting the order into the computer or onto the paper. There are also a variety of resources for shared decision-making. The American College of Cardiology Colorado Program for Patient-Centered Decisions. There's the Anticoagulation Choice Decision Aid. There's the Ottawa Hospital Research Institute Developer HealthWise, as well as Stanford has some decision-making guides. We have some great resources through the PCNA that are available for providers as well as for patients when making decisions regarding AFib care. Lastly, we have the American College of Cardiology has quality improvement for shared decision-making and also gives tools on how to make these decisions with your patient on a daily basis. We'll review our question. You've determined that your patient is a candidate for anticoagulation therapy. According to the ACC elements of shared decision-making, which is the best option to engage in shared decision-making with your patient? A, give the patient information, have them select what they'd like, and order it for them. B, decide which oral anticoagulant is right for your patient and share it with them. C, tell your patient that oral anticoagulants are effective at preventing stroke, but don't scare them away by mentioning bleeding risk. D, use a decision guide to discuss available therapies with your patient. The best option would be D, to use a decision-making guide to discuss the available therapies with your patient. A speaks about giving the patient the information and letting them decide before you order it. Does not cover the outcomes. It does not give you an opportunity to have back and forth conversation. B, that would be similar. We're not in a dictatorship. This is a way to make your patient run from oral anticoagulation. C, tell your patients that it's effective about preventing stroke, but not share with them about the bleeding risk. This would put you at liability if they did have bleeding issues, or if you happen to order something that was not correct for that patient down the line and they did have bleeding issues. It just creates this poor patient-provider relationship when you're not being honest and transparent.
Hi, I'm Jennifer Walker, a nurse practitioner at the University of North Carolina, and I will be presenting on patient education. While the benefit of anticoagulant medications to reduce ischemic strokes is clearly established, anticoagulants are high-risk medications that can cause severe adverse effects. A study by Geller and colleagues examines the rate of emergency room department visits in the U.S. for anticoagulant-related bleeding between 2011 to 2017 and found that oral anticoagulant-related bleeding accounted for 15.5% of all emergency department visits for adverse drug events. This was based on over 3,600 surveillance cases. DOACs accounted for 37.9% of the visits for bleeding, and warfarin accounted for over 60%. You can see the trends of bleeding events for each drug matches with the change in prescribing patterns. Warfarin prescription has declined, while DOAC prescriptions have increased over the years. Although not all bleeding events are avoidable, factors such as complex dosing, non-adherence, and potential for drug or food interactions increase the risk of adverse events with anticoagulants. In response to the rise in adverse drug events, particularly with DOACs, the Joint Commission issued national patient safety goals for anticoagulation therapy, which aim to reduce harm associated with anticoagulant use. The National Patient Safety Goals address 8 elements of performance related to anticoagulation therapy, which include evidence-based medication selection, appropriate dosing, surveillance of labs and side effects, and having appropriate protocols in place for reversal and bleeding events. Importantly, patient and family education is emphasized to reduce the risk of adverse events. Key patient education is comprehensive and requires a dedicated effort to cover all important aspects. Patients should know the indications of the medication, proper dosing schedule, and what to do in case of a missed dose. They should also be given a plan of how to manage mild bleeding events versus significant bleeding events. Finally, they should be aware of the multitude of food and drug interactions. While DOACs generally have fewer interactions than warfarin, clinicians should be hypervigilant about monitoring for interactions, particularly for medications that are strong inhibitors or inducers of CYP3A4 and P-glycoprotein.
Let's go into a question. As healthcare teams provide education in AFib management, which patient-cited reasons for oral anticoagulant non-adherence should they be prepared to address? A. Fear of bleeding and low health literacy. B. Fear of bleeding and twice-daily dosing. C. Forgetfulness and lack of symptoms. Or D. Forgetfulness and low health literacy.
Before I share the answer, we will further explore adherence. Poor adherence to anticoagulation treatment not only puts the patient at risk for stroke, but is associated with increased hospitalizations and a worsened prognosis. A retrospective cohort study by Chen and colleagues looked at Medicare claims data from 2013 to 2016 and found that over 40% of patients initiated on therapy were non-adherent in that first year. Factors associated with non-adherence to anticoagulants have been examined in several studies and include socioeconomic factors, twice-daily dosing, low health literacy, and impaired cognition. In a cross-sectional study of 419 patients on a DOAC published in JACC in 2023, the authors examined reasons for non-adherence. Patients report lack of symptoms, forgetfulness, and fear of bleeding as top reasons for non-adherence. This is a great opportunity for providers and the healthcare team to intervene with targeted education and offer strategies to support adherence.
As healthcare teams provide education in AFib management, which patient-cited reasons for oral anticoagulant non-adherence should they be prepared to address? A. Fear of bleeding and low health literacy. B. Fear of bleeding and twice-daily dosing. C. Forgetfulness and lack of symptoms. Or D. Forgetfulness and low health literacy.
The correct answer is C. Forgetfulness and lack of symptoms. Also, fear of bleeding were top reported reasons reported by patients in the 2023 cross-sectional study published in JACC. Twice-daily dosing and low health literacy have been identified as factors contributing to non-adherence, but they were not reasons identified by patients as causes of non-adherence. Strategies that the healthcare team can implement to support patient adherence include using a multidisciplinary approach. Collaboration with pharmacists or nurse-led clinics can also improve safety. To address knowledge gaps, make sure the patient knows they need to take the anticoagulant regardless of whether they experience AFib symptoms. And finally, to address forgetfulness, using a reminder system like mobile phone apps or smart pill boxes can be helpful. In summary, here are some key takeaways from our lecture. Monitoring individuals at risk for non-valvular AFib can lead to earlier detection as the disease progresses. Current guidelines provide detailed information regarding the use of oral anticoagulants, particularly DOACs, for individuals with non-valvular AFib. Patient-centered treatment plans consider patient and DOAC characteristics to identify the best options for the patient. And finally, tailored patient education and consideration of patient values for anticoagulation therapy can reduce adverse effects and improve patient adherence. Thank you.